strategic priorities, key area of focus. I'll pass the paper over to the chief exec.
Sure. So, as in normal board business, we once a quarter lift our heads up out of the detail of things like the IPR reports, just to check in that we're delivering our strategic objectives, that the programs of work we've resourced and mobilised are having the impact that we would like. So we tend to use our assurance committees, the trust management group and care group leadership team meetings to gain some insight outside of the data reports that we produce for assurance purposes. As Hugh rightly pointed out before, we have a conversation around what we set out to achieve. So strategic priorities and key areas of focus, delivering outstanding care and experience, create cultural conditions for colleagues to be the very best they can be, making the best use of our financial and physical resources and working in partnership. And just checking in as to what we think's gone reasonably well over the quarter and what things do we think actually, with reflection, we could have done better here, or there's some risk associated with these deliverables that we need to highlight. And Suzanne Hargreaves, one of our senior leadership colleagues, leads on this piece of work for us and the reports with colleagues from the back. There's some areas that have gone really well and that the colleague wanted to reflect back. So obviously we've had our CQC inspection. Only last week we've had our soft floor exit. I gave an update around our maternity support programme progress. We've also achieved JAG accreditation, our endoscopy units. We've achieved up to month 5 and 6 our financial plans. We've considered to see some of our investment in urgent care, RLI, particularly the utilisation of we're not calling it a minor injuries unit now, are we, Scott? It's just unit. Thank you very much. Of the facility at RLI. We've seen sustained stroke improvement and sustained improvement in some of our maternity metrics. We've commenced and initiated some core recruitment in our key surgeon agenda and enabled that programme to progress. We've had some great audit reports on our risk infrastructure with some significant assurance from those internal audit services, including our Freedom to Speak Up service. And we've had a 5-star food rating across all of our catering sites. So, as well as the IPR and core metrics, core performance, core deliverables, there are a number of other key programmes of work we've initiated that also demonstrate good progress. And our teams are keen to ensure that the board were aware that that's what they see, that's what they're kind of sharing with their teams. We've also highlighted some areas that concerns and risks, some things that would be even better if we had done something different. And again, some of these issues we've talked about before. So our complaints process, access to capital funding and the estates improvements that we need to make. The numbers of not meeting criteria to reside patients in our beds. Making sure that we are cognizant of the pressures and the risks that things like continued industrial action or winter pressures start to present with us. We know that the latter half of this year is more financially challenging, so Chris is going to talk about the risk-based financial forecast. We've got pressure on winter on things like our temporary workforce and agency spend that Alan and Chris articulated earlier. And general capacity of leadership, whether that's the health and well-being of our colleagues facing a difficult period, or the very senior leadership team that now plays leadership roles at system and place level, puts pressure on us in terms of things for consideration. So there's some of the areas that we've reflected on. They're in the pack in more detail. And I'll hand over after questions, Chair, at my point for Paul, who will lead us through. So what does that do then to our board assurance framework? What kind of strategic risks does that change in terms of our mitigations or the scores that we're attaching to those strategic risks? And building off the back of Tony's update from the audit committee on the review of the board assurance framework as well. Paul's there with just some key headlines from the review, Chair, and hand over to Paul for what that means for the back of the
Thanks, Aaron. So I'll pick up with scores first. So at the end of Q1, there was a request to review the score in relation to camp culture. And you'll note that in the pack, an assessment has been carried out, and that stories is now back up to 16. I think that again is reflective of the comments made by our papers forward today. I think the scoring remains the same. There is an improvement from the initial scores when the initial carried out, but we are yet to be in a position where we can confidently reduce scores towards that target for the very reasons I was saying. we've had some good progress, but as we look certainly into the latter quarter, there are a number of areas of risk which need to be addressed and considered. Picking up where Tony was speaking, the various bits up in the audit committee have been translated into kind of updates within the BAF, which is in your pack. We've highlighted particularly additional kind of either gaps or assurances on mitigations, which will pick up through the work of the assurance committees and the board in the next cycle of meetings. We try to do more to kind of align the board assurance framework to things like our risk register, improvements that have been made there, in connection with the integrated performance report. And when we did the analysis of the high value risk register, the trustwide risk register, what we saw was an escalating position in terms of risk being scored more highly, in terms of finance, industrial action, pressures, and that's consistent with the evidence and missions which have been submitted to the board. In terms of the integrated performance reports, again, consistency in terms of areas of focus within there. So, for example, we picked up already BTE, and within the back there, we picked up a specific action, like the one that Aaron asked for, about more strength in terms of trajectory and our environments. So those kind of areas of discussion, areas of focus, and then translated into the board assurance framework. Hopefully that provides a really good overview of that kind of position that the trust finds itself at this point of the year. Looking ahead to the actions that are needed in Q3. A couple of other points just to draw out. Later on the agenda today, at item 133, we've got the new hospitals programme, and you'll see reference in that report to the governance work. Working with Scotland New Hospitals team, we're continuing to develop the terms of reference for a new board committee. And aligned to that will be an update on the board assurance framework in relation to the new hospitals programme, so that will feature in the next iteration. The other point then I just want to pick up on is that final comment that Tony made in respect to kind of the operation of the BAF, the work that goes behind it. It's been a year now since we've updated our standing operating procedures, so it's timely that we do that work that Tony alluded to help us in our preparations for 24-25. And I'd just like to call out as well that we highlighted with the audit committee, and it's been a year as well since we've done our last risk appetite statement. And given now that we have that move from SOC 4 to SOC 3, it will be timely to do that work, and that will again feature in kind of the work through the audit committee and the executive team. So with that, Mike, I'll commend the board assurance framework to the board and I'll take any questions that colleagues might have.
We'll return to the Chief Exec.
Thanks, Chair. So it's important. So what does that mean then for Q3? You know, what key areas of focus or deliverables we're looking to concentrate on? So obviously, we've got the continued prioritisation of trying to achieve our financial targets and year-end financial position. We're aware and it features on the agenda later today. In preparations for winter resilience and urgent care resilience, again, forms part of our board agendas. The Chief Operating Officer will be presenting that today. In addressing the issues around colleague health and wellbeing and support, we've got the ongoing work around the cultural improvement and leadership work. We've also got the progression of COVID flu vaccinations, and we've got the continued additional from occupational health through this period to support colleagues. We've also got the issue of not meeting criteria to reside as a key risk. Key issue there for us is the escalation to ICB and looking for support from system partners, which again featured here on the board agenda, Chair. So the key areas of focus for us in Q3 are clear. They feature in our work programme. They're attached to the risk escalations in this report, feature on board agendas over this year and the coming year.
Thank you. Thank you, Company Secretary. Any questions or points to raise on this paper? Very clear. We did have more in depth with the audit report previously. So can I just check then? We're asked to consider the progress made in Q2. We've considered that in the paper, I think. Discuss any specific risks and any specific areas of escalation. Again, that's in the paper. The Chief Exec listed them. Prove the actions and focus for Q3. Yeah, can I just confirm again?
You got the
April.
Yeah. Just want to confirm that the quality committee did suggest that when we review this next time, Aaron sort of alluded to the fact that they within the report are some issues around where we could make catch up certain fairly hard to say, but finding the areas where it could have been even better in. And the just in consideration be given to the quality committee suggestion that actually that's specifically reflected in the report, that maybe a separate section, a bit like the care groups do to our in their reports to our committee, their reflection of eating better, and it actually then specifically highlights the issues that we still have challenges with.
Yeah, take that as a proposal to the board. Colleagues happy with that? Yeah, okay, thank you. David?
Chair, sorry to come in at the last late stage, but it was about the key actions for focus for Q3. There are 8 that are listed, and I just wanted to check, just bearing in mind like this morning's conversation, whether there is any specific weighting that are attached to any of those areas of focus. It just seems to be somewhat of a hierarchy, some of those areas which will be more will require more concentrated effort. Thank you.
They would generally be prioritised on the risk associated that's included in the map. So when we talk at either performance reviews or committee results with the exec team, it would normally be in the overall tech team, safe services, so the urgent care, winter pressures, etc. Then it would follow with financial metrics and then the colleague health and wellbeing. But I'll be honest, David, there aren't many to prioritise within there. They are the order of business that need to satisfy over the quarter. But if we had to prioritise resources, it would be on the basis of risk.
Thank you.
Yeah, we know that. Sarah?
Yeah, sorry, I just wanted to come back on New Hospitals programme, which doesn't feel, and I know that part of it is that work is underway to look at how it fits, but it doesn't feel very visible at the moment. And so I'd like to see that come through a bit more clearly in terms of the risks policy, which we know will identify, but also then we're doing in terms of the governance. So I just said to Scott, do we know where it fits? I don't think it's been clear. So if we can see that reflected a bit more clearly, that'd be helpful.
Yeah, we can go. Just to clarify for the minutes, are you asking Sarah then that we look at where it fits in our governance framework? Are you saying it should go through, for instance, quality before it comes here? Are you saying it should come here?
No, because I think when we've discussed it, we think it probably fits separately actually, but then would have impact across the different committees. That's what we've sort of discussed, but obviously that's the proposals to come. I was thinking more in terms of the actual BAF itself, that it's referenced in a couple of places as being part of the solution in a way, or part of the challenge, which, for example, the longer time frame and therefore impacting on estates. But what we don't have is New Hospital programme as something that will need mitigation, action, etc., controls in it, which it does feel like it needs to be there. Does that make sense?
Aaron, then company secretary.
No, I think that's enough, Chair. I think I can pick that up with Scott, just to make sure we reflect it appropriately.
Apologies, Sarah, for what you're really clear in the presentation. So as part of the work that we've been doing, we've obviously trust and done this work previously. Best practice in this area is that you will have a unique New Hospitals programme risk within your board assurance framework, and that's the one that I was alluding to.
Okay. So it'll actually be
It will become a separate risk. We've got something that we're drafting, but I'll share that with you and Scott.
Yeah.
As we take through the new committee,
Yeah.
the new governance structures, we will see something in the board assurance framework. It will be unique, it will be standalone.
Okay, that's really helpful. Thank you.
Okay, thank you. So do we approve the actions and focus for Q3 then? Those 8 points that Adrian said plus the NHP.
Yeah.
Yeah. And in the light of the above review, do we approve the board assurance framework as it stands subject to the comments made? Yeah. Colleagues, thank you. And we'll move on to item 130, Chief Operating Officer Scott, winter plan, please.
Thanks, Chair. I will bring in just to highlight, I will bring in this after I've given a summary. Tabitha and Jane from the kind of general safety perspective, Tabitha specifically from the infection prevention perspective, COVID and influenza, and Chris perhaps just for his other financial elements. But to summarise the paper to the board, which is hopefully self-explanatory, unusually this year, the Trust hasn't been in receipt of external resourcing for seasonal winter additionality. So the specific ask of the board is to approve not only the seasonal winter plan, but to acknowledge that in doing that, it's de facto approving resourcing from trust resources internally as opposed to the use of external resources. I get to the board hears every winter that it's going to be a challenging in winter. I think it would be fair to say last winter was among the, if not the most challenging, and we should be thoughtful that this winter will be a significant stretch for us and our staff and population. Not only because of the compound effect over now months and in fact years of unscheduled care pressure, but that combined with industrial action, influenza, COVID, and in a specific case, the unresolved and ongoing issue of patients not meeting criteria to reside is significant. There's paragraph 3, as you'd imagine, there's a whole myriad of responses and resources and things that we do internally that are largely business as usual that we can gear up and gear down. The specific paper is around the seasonal winter period. I do highlight in paragraphs 10 and 11 that there is a incentive scheme nationally should trust be able to meet that 80% EE performance in Q4 and 90% of ambulance handovers. Our current trajectory suggests that we wouldn't achieve that, but it's worth pointing out that does exist. Paragraph 16 is a table where the internal focus, and it's deliberately internal focus, around the things that we would want to do to try and mitigate the impact of winter are described in paragraph 16. And hopefully self-explanatory. In short, that means that we would seek to deploy 16 additional inpatient beds for 8 weeks in RLI and substantiate 8 inpatient surge beds at FGH for the same 8-week period. There are bits and pieces in and amongst that. There was an ask that we seek to resource an increase in our unscheduled paediatric pathway out of hours, but we are not minded that we have the resource to do that and are trying to find other ways to mitigate that. As discussed earlier, we're not in receipt of plans from partners around additionality over winter at this stage. So I think you'll recall going into last winter that we did see additionality in domiciliary and residential care in both South Cumbria and North Lancashire. We're not in receipt of those plans at this point. So this seeks to deploy internal resources to give some internal additionality, and it highlights the risk faced and some of our mitigations for it. And we seek to deploy that from the this week in January. But I would be keen to you, Chair, to bring in Jane and Caleb from the General Safety Appraisal, then a piece around infection, and then perhaps a broader financial element.
Okay, that's the
Thank you, Jerry. So in support of the winter plan from IPC, effectively professional control, from today, the tickets from today, the winter annual, they're now based in EG as a point of testing for people who have, let's say, flu and COVID, they'll be tested. So if somebody tests positive of COVID, straight away they will be isolated and treated accordingly. And also the areas of outbreak, we are issuing a communication. Louise, I'm not sure whether it's gone today or whether it's going out on Friday to all our staff. Where there is COVID-19 or influenza outbreak on a ward, there are instructions around what surgical masks to use, when and how. And we are also encouraging colleagues who are symptomatic to actually stay away from work. And if they can work from home, that's fine. If they can't because they're really full, then they discuss that with their line manager. So all the instructions in terms of what we are doing as an organization that's more conveyed are going to go out to all our staff today in terms of how we protect everybody. We've already started cohorting sessions with COVID in areas. At the moment, I know it's RLI, which are 3 wards that are in outbreak. And at Fennis, we've got 2 wards that are in outbreak, and all those areas will be expected to follow the IPP guidelines. There is no national guidelines, just to be clear on that, because everybody saying, what's the national guidelines? What we are being advised is that we do what's safe for our organization from chiefness perspective. And we're working alongside occupational health with Ali in terms of the COVID injections and influenza. So if you haven't had it, please go and have it. Thank you. That's what we're doing from an IPP.
Okay.
Again, in support, I think it's every year we have less reduction of support. So we start each year saying what was worse than winter this year. And I think the flu is predicted to be tough each year, so again vaccines. But I think we also know that there's no additionality because there's very little additional primary care. So our primary care colleagues have informed us that they probably have limited response also. So we understand to see more and more patients. And I think this plan really gives us the best chance of providing the safest care that we can over the winter period, which is going to be difficult.
It is so obviously every winter we do the winter plan, but we also have the summer pressures. I agree with you, Jane. The ladder seems higher every year. We're not getting any extra resources. In fact, every year we get less resources. It is a major concern that our patients are safe and our staff well-being is kept to the highest level that we can. I know you can't predict it. Are we getting any assurance? We get the mitigation. We get the people are being encouraged. But have we got things in there that says board will get assurance around patient safety?
Go ahead. I think with the mitigations that we've put in place in terms of supporting, what I'm saying from a chiefness perspective is we'll make sure our patients are safe. That's why we started from the point of entry into our clinical area and make sure our staff are also safe. Well, I'm saying it with caution because I can't predict the numbers of, I mean, we've talked about not meeting criteria to divide and everything, and I know Aaron and we're going to take us to the system. We have got a lot of mental health patients as well with no beds, and we are actually looking after them. And with winter coming, the pressure will only escalate. So I'm just making a point to say we will make sure patients are as safe as possible when they're in our care, and we'll do whatever we can in terms of staffing numbers, making sure we've got the right staff at the right time to support. That's all I can say.
So I think it's important for the board to recognise what assurance you currently have as a board around safe services and how that's generated, either through 3 times a day site safety meetings, the triangulation board, accreditation board visits, the issues we have around things like the executive review, the incident rating, share lesson. So we have an infrastructure in our organisation that the board can take assurance on at any point and dip in and out and take reassurance as we move through those processes and give updates at board. That doesn't change. If anything, we escalate that infrastructure through the winter with potentially more regular site meetings, more leadership visibility on specific shifts, particularly around the bank holidays and post those bank holidays. So the board will continue to take that assurance through the metrics and the performance and the indicators we have currently. We have an escalated period of risk, which is what the winter plan is designed to address, and to the best of our ability and knowledge and resource. That is the plan that the leadership team, the operational teams have come forward with to mitigate the winter pressures. In the way that James just articulated, we believe this is the best plan we have with what we've got available to satisfy a safe winter. Over and above that, we have a number of conversations happening within the system across primary care, community, mental health and local authorities to share what respective risks look like within each of our respective areas and what we could do across the system to mitigate risk. There's a meeting with the ICB leadership and the chief operating officers around what I would call the operating model for winter. So the strategic command centre, how you initiate risk escalations, maybe facilitate transfers over escalations. So without going through all of the mechanisms that the board has available, that is how I would respond to that question, Chair. And it's important that the board recognise that those things are in place.
Yeah, thank you. You've answered my question. Part of the rationale behind asking it is we are a board that has a meeting in public, a recognised for a public meeting. So your responses will provide reassurance to members of the public who observe our board that we have the correct planning in place. And yeah. Okay, I'm checking around. Sarah, Chris, Dominic. Chris, do you want to come in now? Sorry,
I think it's important, Chair, that the board sort of explicitly considers the financial.
I'll come to that.
That's.
Sarah,
That was actually going to be my question.
Mm.
So,
I did just check with Tony.
That wasn't going to be the question, but
I'm just. Then you want to come in?
Yeah, there
Is
is,
it fine? No.
no,
Right, I'll bring Tony
Yeah.
then you. I'll come to the final.
it's kind of Scott, I'm just looking at the table on 157. Improved use of discretionary fund, LCC, robust aftercare service. I suppose it's the additionality. Wearing a different hat, it's how we know what is being invested is additional and above the line in terms of what ordinarily would be provided with what funding. Do we know? We don't know that. Not from local authorities, no. Should we, I'm just asking the question, should we know that? Because as part of a two-way obligation commitment, it's about the transparency and holding to account each other, because if that isn't, I'm not saying this wouldn't happen, but if that wasn't delivered to scale and scope, then your ambitions and the million that is being proposed to spend is just compromised, isn't it? Because you're not getting the level of report and activity.
With the board's approval, I'll take that as a proposal. That me and Aaron will take that, the PCD and the ICD. They probably make sure that's.
yeah, I think my question was very similar. It was regarding the absence of the plan from the local authorities and, you know, what kind of impact that has and when we might even have sight of it, if at all.
I think just bring us back to the previous item, we did discuss the priorities for quarter three. One of them was the criteria to resign, so I think it's right that we'll follow that up. And Adrian, I know you were in terms of checking the bringing in the funding.
Thanks, Chair. I mean, it's connected to those points really. Just in the risk section, whether we just needed to formally record the potential for differential levels of services, patient outcomes, health inequalities as a result of the support that we're having from our top tier authorities, particularly with reference to the element. I think it's a real potential, and it just formally needs to be recorded by the board that that's something which we're part of the plan we'll seek to mitigate. Just anticipating.
Refer again, colleagues, to previous agenda item, Scott's report. You know, that if you take the therapy, not the therapy, talking about, as you say, be a third of our beds been taken by patients who really shouldn't be here. So it is becoming a major issue around population health community. Thank you for that. Bye, Sarah. You go with the finance, then I'll come in and then I'll let Chris come back.
So I think what I was going to say, clearly what the plan sets out is how we can help to maintain performance and patient safety. The impact is the financial impact. And so my question was whether our forecast that we now have through to the end of the financial year includes the £1 million that's reflected in this, or whether it would be in addition to April.
Scott, then with Chris, do you want Scott to come in on that? Let's say both.
Just be more specific one, because if I may, so it's not to correct you here, but just to be really clear for the board, this plan is not direct reward performance. This plan is safety. So this plan's not to try and sustain a number, a simple tourism data set. This plan is to mitigate patient safety.
Put that clarification. Question that Sarah's asked, which is my question, have we budgeted this 1 million or is it an extra 1 million deficit?
We have budgeted in the check, and it's still an important decision to go for it. It was the provisions that we made of funding this and is in the current forecast risk assessment.
I know stress the word risk there as well as the forward forecasting. Taking into account, I think, some few warnings from the CFO there that I shall ask the board to consider. Anything you want to add, Chris?
I think it's important, Chair, that we're an organisation with a plan for a deficit that's identified risk to that platform. So we're in a position where we're potentially taking a decision to spend additional money in the context of being overspent. Yeah. So how do we do this? Remember, Scott's point there is really important. This is how we deploy our resources where identified to meet patient safety. If you look at our balance scorecard, we're an organisation that's demonstrated that we've delivered improvements in quality and safety as evidenced through software, exit process, confirmed by pre-report scrutiny, and other independent external processes. We're delivering our current forecast risk assessment shows an organisation seeking to deliver or planning to deliver greater than 5% CIP, largely recurrent in the current position. And the performance indicators, notwithstanding some of the issues that we discussed today, are compared positively within our system. Financial decision, as I said, we do have provision for this. It is a decision to spend more than we have in the run rate. We have to recognise that the forecast risk is not driven by this decision. This is the decision in that context. The forecast risks associated with simply additional stretch targets, the impact of industrial action that was unplanned, inflationary cost pressures and funded elements of pay awards not meet criteria to reside at 5%, which means release 4 million payments. Not only we have them to continue spending the 4 million, by the way, the full cost of criteria to reside is greater than that. This is a provision that we're having to make in the context of that capacity. So I think it's just important that we're clear about this. My view is that we have, and later today, going to take through to the board through a really robust, carefully considered, ambitious, targeted process about how to best manage the forecast risk. And our commitment to that underpins this decision.
To take that, I want to be clear that all members of the board are fully aware, consciously aware that it is up to a maximum. It's not releasing 1 million. We talk to a maximum. Let's be clear about that. But we need to be sure that when we get to the decision making, for that's the board to do today, that it is in the full knowledge that it is a risk. It is an extra spend. Even though it's budgeted, it is a request to spend more money. I would only ask Chris one question. What if we said no? How safe are our patients?
I think I dealt with that in the first comment. It is that this is a really carefully considered and developed response to identified people.
Putting that in the context that Scott outlined as well. Okay, I just want to make sure everybody's clear that nobody in the future comes back and goes, oh, that run rate's gone off. When did that happen? When was the decision made? And why was it made? I want something very cautious here. I know we're giving this item slightly longer than that. Tony?
Yeah, I'm very reassured by what was described. Just a couple of applications. One is on the timeline, because I think something like Beverly's wing is going to, but we know it's never straightforward.
So what happens when the magical date arrives in February, the same, we're still in the same state, so is that kind of come back to the board or what, to switch it all up or to extend? The second thing is, I'm getting into detail here, but on page 159, the open additional beds or 6 inpatient beds, 16 inpatient beds. I'm not sure if those are taken from existing beds or given that we've got a third blocks in bed forms. But what happens if those beds and the staffing on those beds are going off?
Scott?
And then it has to be covered by agent. I'm just asking about the recurring, the double counting costs, because that's life, isn't it? People become unwell, so I'm just asking about that.
Yep, good question. So, the RLI is our surge ward, so ward 6, our refurbished surge was what we used last winter. It was planned to open for 8 weeks. We managed to open and close it in 6 weeks, and it's remained foul since then. So it is our bespoke surge ward for this week, so it's not quite capacity. To your second point, unless we were to declare the local 4, on the advice of the chief medical officer and chief nurses that we were having disproportionate clinical harm, then we will close it in the 20th of February, because you're right, we could feed it for a year. So the point I was making earlier, it won't be based on performance, it will be based on general pressures, it will be based on this is how much resource we have, this is how much we will open, and it would have to be a very, very serious situation that was declared for us to even consider to be open beyond that, which would get highly unlikely.
So that's really helpful. To just, the other point was, so whatever that ward establishment is, someone is likely to become unwell, and therefore those rotors need to be covered. Then in that sense, you're covering the cost of the employee who's doing the work, and then the cost of the person who's coming in to cover that work. Is that included in this budget? How's that managed? Because that could exponentially kind of become an additional cost pressure.
I'll summarise if that's all right, John, to the CFO. Is the additional cost of agencies that are required to pass that away covered in the 1 million?
Thank you.
Yeah, we've costed the anticipated staff and
That's great. Thank you. Okay. Chief Exec, last word on this, please.
Yeah, it's so we don't apply the same level of debate discussion that I've just heard alongside the other 550 and 600 million pounds we spend. So that's quite a purposeful, board considered discussion around something that happens every year. So we expend and deploy this kind of infrastructure every winter. It's in our plan. It's part of the operational expenditure for as long as I've been executive here, to a varying degree, 10 years. That's how we plan for winter. The factors are income. We're used to having a different income profile that tends to offset this, so it stuck out as a different thing this year that needed more consideration. So my reflection isn't necessarily critical of the board discussion around the single item of expenditure over this period. It's more a reflection as we move into next year's planning, that we have all of this in front of us as we make decisions to support the operating plan, including how we're going to approach winter. So we should have had the conversation about winter resource, how we're going to deploy right at the start of the planning period. So there isn't a surprise conversation here. Then if the factors of income change, then we highlight that as a risk to the income position rather than a targeted conversation about expenditure through winter, because it's part of our normal operating business. So if it's okay with you, Chair, I'll make sure with the exec team that we build that kind of focused scrutiny and agreements as part of the planning process for 2024.
You took the words out of my mouth, because I was going to end before we make a decision about the reason I spent some time on this is the difference this year. We are really under a lot of financial pressure to get to a balanced budget at some stage. And that is a real issue for the trust, which hasn't really addressed that in the past. And we're going to have to address it. So hence the added focus. My second point, again, Aaron, to support you, we had 10 minutes on this item, but 4 execs spoke on it. There's no way that we're going to cover that in 10 minutes. I'd asked the execs and the company secretary to discover the rights come from the board, that we allocate the right amount of time to the right agenda items. We've got 25 minutes over now, and we've still got 5 items to cover. So I'd ask and request that you take that away. But let's go to the decision. Approve the seasonal winter plan. Yeah. And in so doing, approve the resourcing up to the maximum. Please, think the request to the execs to not go away thinking that we've approved £1 million. We have approved up to a maximum, up to. If you spend 200,000, that's happy. Don't go home. We've got to spend £1 million. I know we all need to say that. Okay?
Just a quick question, Chair, on that. Is there a mechanism in that period to measure what that looks like?
Yeah. That will go to finance subcommittee. Yeah, okay, thank you. Okay, colleagues, move on then. Item 131. I'm conscious you need to have a bite to eat before we have the private board. So let's see where we go with this. Chief Operating Officer, emergency preparedness, resilience and response.
Thanks, Chair. Can do this in 1 minute, and unless there are any questions. It's a very technical exercise, but a very important one because it is a trust declaring in public that it is adequately prepared for emergency preparedness, response and resilience. I, as the Accountable Emergency Officer, have signed the self-declaration based on the self-assessment where we believe ourselves quite a high crossbar to be fully compliant against 55 of the 61 recommendations and partially compliant against 6. There's lots of detail in there, much of it's technical. As you say, this is not an area that's alien to us, although we've not declared any major instance, thankfully, or been involved in any significant major instance. It's something that's well practiced, well rehearsed, and I would commend it to the board.
Okay. Any exceptions or escalations will be reported up here. We're asked to review the summary attached. I'm assuming colleagues have read it. Yeah. Happy with it? Yeah. Review the overall assurance rating. Yeah. And approve the core standards action plan. Yeah. And AO to sign the statement of compliance. Thank you, Scott. Thank you. Nice and concise. 132, provide a collaborative update.
Thank you, Chair.
Please.
Very briefly, so the report is the standard report that comes from the provider collaborative board into each of the provider trusts and gives an update on the business we've conducted over the last month. Progress updates that I've given previously on things like the Central Services Transformation Programme, the clinical services work, and also pathology, which is another key work stream for the provider collaborative. It is important to note that for the pathology collaborative in particular, we're expecting a business case to come through the board cycle in the early new year. There will be a paper at the next board that highlights the process, the framework and the criteria for that business case to go forward. So the board will have oversight of that early. I have today written out to the company secretary of the provider collaborative to make sure that over this next period we move away from general and specific board action updates from the provider collaborative board to more specific agenda items where the board needs to consider key risks, issues and deliverables. And to be clear for the board, Ali is our executive lead for central services, Scott is our executive lead for pathology, Jane will be our executive lead for the clinical services work under our clinical strategy. So as we take that work forward, we'll start to bring separate agenda items for board to consider as decisions need to be made.
May I ask the first question, Chief Exec? Because obviously the Council of Government is really interested in this, that we have the capacity and the capability to meet these additional responsibilities of our colleagues in the executive in their PCB activities.
So they're included in the objectives and resources that execs have got available for them this year. I think as those programmes of work continue to develop and move into delivery and decision making, we would need to consider what the leadership resources are for execution. I think particularly for central services, there's a central services leadership model in the system that will develop over the coming months, which will take resources away from the work we do locally. Similarly with pathology, I think the clinical services work as that progresses, that's likely to need, I think, operational and clinical leadership and control. So that's
Colleagues, we're asked to note the report and obviously get the monthly updates. New hospital programme Q2 report, item 133, Chief Operating Officer.
Yeah, again, without rushing, I can take by exception. I think it's well written by Rebecca and the team. That I would draw the board's attention to the bullet points at section 6 on page 186. So the 3 core activities as we speak are significant work around the enabling work business case. So there was lots of work, much of it commercially sensitive. in looking at preferred site and commercial negotiations, so that goes on as we speak. The governance model, so now that the programme split into the Royal Preston Hospital and Royal Lancaster Infirmary, then the governance model to kind of move us on to that stage of two separate building projects versus the previous kind of system-wide arrangements continue through the system oversight group, the strategic oversight group, sorry. And then the work is starting, and I emphasize starting on seeking the best approach to consultation around the new hospitals, and also it's a very technical and statutorily governed piece of work, so we're more to follow that will come to the not only the board but also council of governments around the post consultation approach that I would expect to start to come through into the first quarter of next financial year. And the final part then is with Paul's help and Sarah's support as the non-executive lead, we're crafting a proposition around the board subcommittee for the new hospital programme and the terms of reference that we published that, and we'll bring that back and what the next process we want to. Any questions?
Concise.
Just very quickly, could I just ask what's happening to the money for Barrow? Because there was some money supposed to be coming to Barrow, wasn't there, as part of the new hospital program? It's just that I've not heard anything about it for a while. And
Sure, I've got two, possibly the same answers that we give for RLI, which is that funding allocation letter that we received. We remain committed to deploying that in Barrow as stated in the strategic outline case. When we get closer to things like enabling works and consultation, we'll then have to give more granularity around that. So it's certainly not gone away. It's certainly still a strategic intent, and I would hope in the next calendar you will start to see us create more detail around that.
thank you.
Happy to accept the report. Thank you. We know the progress undertaken in quarter two and note the activities planned for the next period. Attendance monitoring register you have, schedule of business, nothing to add to the existing schedule. No urgent business being brought to our attention. Okay, then I'll close the meeting, colleagues, at 12:06. See you at the next meeting. We're due to have the private board at 12:15. I'll move it to 12:20. I'll be like a sheepdog and herd you all in. By 12.